Can you not see me? I've got my camera on.
No, maybe it's.
There you are.
Let's put it on that.
Morning.
I have to confess.
Oh, there we are.
My camera is just not coming on.
Okay, I'm gonna go ahead and kick us off since we are at 10:30.
Good.
Welcome everybody, and I'm of course delighted to be here in Martin's stead. I think you're all aware he has a CQC inspection today, so unable to be here. But that's great. I think it's our last council meeting of the year. So let's get going. We have a couple of really good presentations. Julie, apologies. I think Julian, I'm aware, can't be with us, and Alex is here in his stead. Any other absences?
Yeah, I've also got apologies from Julia and Heidi. So Liz Chapman will be presenting the patient experience report.
Excellent. Thank you for that. And I am going to ask if we might shuffle the agenda slightly. I know that, Alex, you have something of a dilemma. You have to leave, I think, by midday at the very latest.
That's right.
And in that case, what I'm going to suggest is that we move the executive report in its entirety. There are two elements to the executive report today, one from Liz relating to patient experience and the other from Alex on performance. And I'd like to move the whole of that agenda item forward and take it immediately after matters arising, and just keep things simple. And then we'll continue with the rest of the agenda, if that's okay. I know, Andrew Horn, you have to leave at 11:30 as well, and thank you for letting me know that. But I think Paul is going to stand in your stead, so we'll just leave that agenda item where it is, unless that's going to create awkwardness for anybody.
Not at all.
Good stuff. Okay, with that, any declarations of interest? No, I'm not seeing any hands raised. Any amendments to the register or suggestions for the agenda? No, good, thank you for that. We'll take the minutes from the last meeting. Any corrections or adjustments that anybody would like to see? No, good. Julie, I'm relying on your eyes and ears a little bit. I work off my iPad, so I may not see if hands get raised. But I see, Raymond, you have your hand up. Please go ahead.
Yes, hello everyone. I just wanted to say that I read through the audit committee report. Yeah, are we having a presentation today on that?
We are indeed, Raymond. Do you want to?
In that case, I'll wait until that report comes up. Thank you.
Thank you. So any corrections or adjustments to the minutes of the last meeting that anyone would like to see? No, I think we've given that a bit of airtime. And Julie, are there any matters arising from the previous meeting?
Not that I'm aware of.
I'm not seeing any hands raised in that regard, so I'm going to take it that
Perhaps
there
I
are.
could just, sorry to butt in.
Go ahead, Tom.
I should say I mean, I've got one request for information there, which nothing has, I don't know that we've had anything back, there's nothing minuted anyway, about early termination of PFI. Now, where is that? On page 4 of these minutes, the bottom of page 4. And I think there might be another one somewhere. Oh yes, there's a question there about whether ethnicity was part of a RIO record or was added to a complaint when the complaint records ethnicity.
Yeah, thank you for that, Tom. So as far as you're aware, those two questions haven't been responded to yet. Is that right? You've gone on to mute, Tom.
Yeah, not that I know of.
Okay. Can we follow that up, Julie?
Yeah, that's fine.
Thank you, Tom. So with that, we're going to move straight to what was item 9, the executive report for the trust. And Liz, are you with us? I hope you're with us.
I'm not sure Liz is with us at the minute.
Would she normally come a bit later?
She might be. I've just messaged her
Okay,
to say that we're moving it forward.
that's fine. Alex, would you mind going ahead?
Of course. Good morning, everybody. For those who don't know me, my name's Alex Guild. I'm Deputy Chief Executive here for Julian today, as Naomi said. Good to see you all. And I'm going to take the performance report broadly as read. And I hope you find the introductory context and information there of use, just in terms of our current state and outlook in the trust and in the system.
Can someone give us the page number for that in the
51.
51, thanks.
No, beg your pardon.
No, it's not 51.
82.
82.
Thank you.
Good. Thanks.
In terms of our overall performance, in terms of the national metrics and quality and safety metrics, we report to the board and are held to account for in our systems, and nationally in some cases we are pretty steady and stable, and nothing exceptional to report there. Our financial position is ahead of plan slightly in the first half of the year, and we expect to come into a break-even position as a trust within our systems by the end of the financial year. We know on finances that the efficiency requirement on the NHS will come back into sharp focus for the next financial year, and so the team are working on a range of potential efficiency and transformation programs to respond to that. As you know, in the COVID period, our financials have been heavily supported as we respond to the pandemic. So, as you might expect, efficiency coming back into focus. You've got a summary there of our risks and current outline of strategic risks in terms of our board assurance framework. You can see latest actions and mitigation plans in play around those. So I'd be very happy to take any questions on the report. Tom.
Just to clarify, first thing is whether the surplus deficit, just remind me whether the surplus deficit includes capital expenditure or if it's a separate account.
It's a separate account, so that's our revenue expenditure account is in surplus by $1 million to the end of the month 6 period, forecast break even.
Thank you. And I wondered if you could say anything about the large number of assaults that the figure does seem, I mean, this is something that the trust has been working on, and we don't seem to be making much progress really. So
in terms of our overall trends and our benchmark position,
86, page 86.
We are making progress. It doesn't sing off the page here, and there is a very strong focus through our quality improvement programme on staff assaults, particularly within Prospect Park Hospital, where the majority of the wards have this as an improvement driver metric, and they're focusing daily on it. We often find that there are one or two or a few single individuals that drive spikes in our assault. We've got good visibility on that, and will often require individual mitigation plans to be put in place for those. But our general trend is strong. Our focus is very strong in terms of the impact and understanding of assaults and the work on it.
Thank you.
Raymond. And then John.
Yes, thank you. It's just a pedantic comment to make. The text is extremely small on these slides, and there's a lot of unused white space on the slides. I just wondered if next time perhaps the white space could be used, please.
Of course, we will reflect on that, Raymond, and fix it. Thank you.
Thank you, Raymond. John.
That's why Julian put you in today, Alex, because it's gone back to small. Last time you managed to get it big, because we've been talking about that for years, but there we go. Yeah, I'm just looking at the out of area placements in the East. It seems an enormous increase. I mean, I know these things happen, but that is a massive increase in the number on page 93.
Yeah, we have some significant pressures on our bed capacity at Prospect Park Hospital, which is our mental health inpatient service. OPEs are common in terms of either need or capacity issues. But at the moment, I've looked at our daily bed management numbers yesterday, and we're up to 31. That is some of our highest placements out. We know there are potential quality impacts if those patients are sent far away from their place of residence for too long. But we have put in additional capacity outside of Prospect Park in the local area. So the majority of those patients are being supported with appropriate quality of care safely in the right place.
Out of area in this case isn't mean necessarily a long way away, which is good. I mean, is it worth including that in future, Alex? Or is that not an appropriate thing to do in this report? Because I
think it's helpful context, isn't it, John? Because that would have helped you understanding. So we'll get that put in.
Okay, thanks, Alex. That's great.
Can I just make a request for folks to go on mute if they're not actually asking a question? There's a bit of background noise. Thank you. Tom, I think that's an old hand, is it? Any other questions for Alex? Thank you for that. Is Liz with us, Julie?
She is, yes.
Excellent. Sorry, Liz, I can't see you, but that's fine. And thank you for joining us somewhat early.
Not a problem. Good morning.
Good morning. Hand over to your good self to take us through the patient experience Q2 report. Could you just point folks to the right page number before you go?
Of course. Good morning, everybody. The patient experience report is on page 53 onwards of your papers. Thank you. So to give you a brief overview, there's been a slight increase in the number of formal complaints that have been received during Q2, as shown on table 1. However, if you look comparatively for Q2 last year, we're around the same number, so I'm not concerned by that. Where we have seen quite a significant increase is within the number of formal complaints received for our CAM service. So you'll note that has doubled. Although the numbers are low, they have doubled in terms of activity. Now, as we're well versed in this group, we know the pressures locally and nationally on CAMs. So there is a lot of work that's been going on and continues to go on within the services, looking at recruitment, care of waiters, making sure we're seeing people as swiftly as we can, and also engaging with our partner agencies and looking at the different tiers of support and how children, young people and their families can access that at an earlier stage rather than having to wait for the support from secondary CAMs. In terms of our response rates, we've continued to sustain a 100% response rate for formal complaints that are resolved within a timescale agreed with a complainant, which is a fantastic achievement, considering the levels of activity that we've had, absences. Thinking of Q2, summer period, we've continued to sustain a 100% response rate, which is absolutely amazing. In terms of ethnicity monitoring, you will see that we're continuing to include ethnicity monitoring for people who have had a complaint made about their care. Now, this changed slightly. So in previous reports up to Q1, we used national data from Public Health England on our ethnicity and how that looked kind of within our Berkshire and surrounding areas. But we changed that from Q1. So for the Q1 and this Q2 report, we're actually basing the ethnicity monitoring data on our cohort of patients. So we're looking at those who were seen in Q4 of last year. That's the most recent data we have to hand, because we feel as though that gives a much more representative view of the population that we hold. Moving on slightly, you may notice the Parliamentary and Health Service Ombudsman table, so the PHSO. These are the kind of the secondary stage in the formal complaints process. You'll notice that there has been a flurry of activity. And when I first, noticed this, my heart sank. However, I know that the Ombudsman for the last 18 months have had a pause on their systems and their processes as a response to the pandemic. I'm not sure what's going to happen moving forward. Obviously, we're in a challenging time ahead. However, they have had a period of of heavy recruitment within the Ombudsman's office, and also a review of those cases that they put on hold. What I'd like to point out is that just because we've had this flurry of activity, it doesn't necessarily mean the quality of our care has got any worse or is bad. What the Ombudsman are predominantly asking for is information to help them make a decision on whether or not they're going to investigate, not that they are. And I feel it's important to separate those two things out, because it's not necessarily, that high level of activity on the surface, could give a misleading view. Very proud to say I Want Great Care, the new patient survey and feedback mechanism went live this morning, which is a fantastic achievement. Thank you to all of those governors who've been involved with this process. So we have gone live, and a lot of work has gone in, a lot of meetings, a lot of toing and froing, making sure we're hearing the voices of people, and worked with a leading provider, I Want Great Care, to make sure that we're providing a service that is equitable, accessible, and does what we all want it to do. So I'm really, really proud that we've done that, and a huge thank you to Natalie Zacharias, who's been spearheading this process. I note that there's a query from the Governor Assurance Group. Unfortunately, I was unable to attend the last one, about the comparative figures with Sussex Partnership. So in the report, you'll see there's a table, and it's based on something called the KO41A, and that's our national benchmarking for complaints. So every quarter we include a table with the most up-to-date figures that just says how are we doing comparatively to our peers. And if you look at our numbers in comparison with Sussex, well, Sussex have nigh on 200, which is a huge comparative increase. I'm not quite sure why that is, to be honest. So what I've done is I've set up a meeting with my colleagues in Sussex to understand what their processes are, if they're managing complaints differently to how we are, a bit about their demographic, their characteristics of their patients, because it is stark reading. It's, for some comparative trusts, it's 4 times the number that they've been receiving. So I'm curious to see what they're up to, and if there's any way as a system we can support each other. And lastly, but not least, a little bit of an update from me on a piece of work we're doing that aligns with our quality improvement methodology. So there's something called Just Culture in the organisation, which is about how we look at incidents, complaints, HR cases, and how we support our staff. And it's really a culture change. So it's this no blame. As part of that, I've got a meeting next week with Children, Young People and Families Division and their investigating officers, their IOs for complaints. Because what we really want to understand is, how does it feel to be an investigating officer? Because, from a complaints process, we send these complaint cases out and we work and support our IOs, but how does it feel? What are the pressures? Because the staff are also having day jobs. They're not just IOs. So we want to understand how we can support them best. So we're starting with CYPF, so Children, Young People and Families, and we're going to develop an A3, which is our initial quality improvement methodology piece of paper and plan of what's going on, what have we identified, and what are our initial steps, what are we hoping to achieve, and we're looking to then roll that out wider across the organisation. So we're starting with one division and then we're going to roll it out further. That's all from me. I hope it's helpful, and I'm more than happy to take any questions.
Thank you, Liz. Some really good touch points there and insights. I'm going to go to Guy first. Guy.
Yeah, thank you. Thank you, Liz, for that. On page 57, community health inpatient complaints. Oakwood unit, 4 complaints for care and treatment. I know it's only a relatively small number, but should we be concerned about that?
I'm going to say no. The reason for that is we've been working very closely with Oakwood, because we've noticed over a period of time they've been on our radar a little bit more. I'm not overly concerned. I know they had some agency issues for a period of time, but having spoken with the ward manager and the clinical governance lead, there's nothing there that's flagging as a concern.
Okay, thank you.
Tom Lake, go ahead.
Yes, thank you. First, just an observation. if you think that complaints are gold dust, then you've got to admire Sussex Partnership.
Yes.
And indeed, you'd think as well, the IOs, the investigation officers, would be a great source of suggestions as well as direct conclusions from complaints. And just lastly to say, I was going to mention Oakwood, but I was going to mention, it seemed to me that it was Daisy and Oakwood that my eyes were drawn to, and I wonder if you've got anything to say about Daisy Ward at Prospect Park, on the same lines as.
I don't. I mean, we share this information with the clinical governance leads, with the clinical directors, and we have very open and transparent conversations with them about quality and say, you know, we've noticed you've got an increase. Is there anything going on here? Daisy Ward, again, there's been nothing highlighted to me that is of grave concern. I think one of the things that we do have sometimes, are we have some patients who may be particularly challenging on some of the wards, and maybe we're not meeting expectations. However, I've not been cited of anything in terms of clinical quality, care, things like that, attitude of staff that have been a cause of concern. But I will absolutely take those 2 points back with Oakwood and Daisy and just highlight again that it's been raised through this forum.
Thank you.
Thank you, Tom. Jane.
June.
It's me, June.
Yes, Jane Carmichael.
Thank you. Thanks, Liz. My question is running a similar vein to the ones that colleagues have already asked. And I was looking at CAMS on page 58. And I was surprised actually the wait time wasn't a bigger complaint than it usually is. So that's progress of a great order. But when you look at attitude of staff and care and treatment, I'm interested to understand whether care and treatment is more about patient expectations not being met rather than we weren't delivering the appropriate level of care, etc. So it'd be really helpful to understand that from a patient perspective and how that's landed within the organisation. And then the attitude of staff, what was behind that and how much of that may be an indication of some of the stress that people may be under currently. I'd like to understand, the themes behind the themes, if you like.
Absolutely, thanks, June. So in terms of the attitude of staff, one of the things that has come through, which segues nicely to what you said, is, to be blunt, people not doing something when they say they will. So, for example, staff saying, I'm going to send a report out, you'll get it a week Friday, and then it not going. And then people are coming back saying, well, you said you would do this and you didn't ring me when you said they would, which is indicative of the pressures that staff are under. However, we've done a big push with all of our services around meeting and managing expectations and not setting ourselves up to fail with people. Because it's very easy while someone's on the phone to be saying, oh, absolutely, I'll get that to you. You put the phone down and then you move on to something else. So we're very, very aware of that. In terms of care and treatment is really, it's a bit of a catch-all theme. So when we categorise within the complaints office complaints around care and treatment, quite often they do have other elements in them. The way the system is set up is we can only go 2 levels down within our themes and our subjects for complaints. However, if it would be useful, I can do some further analysis on the CAMS complaints and send it through, just so you can see in a little bit more detail what some of the care and treatment complaints are about.
Thank you, June, and apologies for calling you Jane.
I answer to most things.
It's because I'm blind, frankly. But Tom, the other Tom.
Yeah, and just going back to the complaints across the country, and we've brought it, and you're aware of this and brought it up before. But when you're meeting with Sussex, you could discuss, is there any chance that rather than just getting bare numbers of complaints, that the country could actually do complaints per service engagement or complaints per head of population, because the raw numbers are almost useless. Well, they show very stark contrast, but you can't read much into raw numbers, and it is just kind of, it just makes me feel sad or silly that across the country we're using something like this which isn't fit for purpose.
Thank you, Tom. I'm mindful this call is recorded. However, I do agree with you. Data is only as good as the story it's telling. So I hear what you're saying. What I have done in the past is try to set up a bit of a local network for complaint managers to share some of the information, share our patient experience reports. But I'll be honest, lots of people aren't very keen on doing it. Not quite sure why. And they're not all published on their websites either. But I hear what you're saying, Tom. Now, there is some more information on the KO41 report. It doesn't go into necessarily service types and service groups. It's more type of organisation. But what I can do is have a further dig around and see about their attendance numbers and see if there's anything else I can pull out, because quite often percentages are quite useful, aren't they, for things like this? They tell a little bit more of a story. So I can do some more digging.
Yeah, but it's the question of, you know, if enough trusts told the central body that this is plainly stupid, that we're embarrassing you, the central body, by reporting on figures that really need to be properly accounted for.
I hear what you're saying. What I can do, Tom, is I can feed that back up through my colleagues at NHS England. I can have a conversation with my colleagues up there and feed that back.
Yes, please. You can quote me if you want.
I will, Tom.
Thank you, Tom. I share that comment.
Well, coming from a service industry like British Airways, and Naomi, you're from it, if anybody presented that in a meeting of management, it would, yeah, well, they wouldn't lose their job, but they would be told, "What are you doing?" You know, it's just inconceivable.
Absolutely. Yeah. Graham.
Yeah, just on that, I mean, a raw number of complaints without some qualitative analysis is somewhat meaningless from my point of view. My question is about Table 6, and maybe I've missed something, maybe I've not understood something, but does Bracknell not feature in Community Health Service?
It absolutely does. We just haven't had any complaints about them.
Ah, right. So maybe if you have a table putting zeros in, might tell a story.
Okay, Graham. Yeah, not a problem. We took that out.
I just wondered. I wondered where they got to.
No, they're definitely there. No, I hear what you're saying, Graham. We took it out because we'd had previous feedback that people only wanted to see the areas that had the data, but it's not a problem. We can pop that back in.
Can I very quickly go back to Tom's point? The data is actually out there in the big wide world as to the number of population in any particular area, which does include NHS trust areas. So if you need it, then I can point you to where that data is and explain how I use that data to get the population, be it the number of children, for instance, in any particular local authority in my case, but it can easily be a foundation trust as well.
Thank you, John.
I don't need it. I just want the central authority to stipulate reporting something sensible.
John, are you happy for us to touch base outside the meeting about that? Because that would be really helpful to see the data you're getting and how you're getting it and how it's being used.
No problems.
Thank you, John.
Thank you, Liz. Any other questions for Liz? Thank you. Good session and excellent questions. Liz,
thank you, everybody. Thank you very much, everybody. Take care. Bye-bye.
I'm going to move us on to the next agenda item, improving physical health checks for people with severe mental illness. And I don't know, Debbie, if you're with us, did you want to tee this up or shall I hand it straight over to Kerry? Kerry, I think it's over to your good self.
That's fine. Good morning, everybody. I think it's page 10 of the papers, but I will just share my screen to do a short presentation. Bear with me. Okay, so hopefully you can all see that. I won't be able to see hands, so I'll perhaps just take any questions at the end, if that's okay. So I'm Kerry Harrison. I'm the Senior Physical Health Lead here in Berkshire Healthcare, working with the community mental health teams around the physical health of people with serious mental illness. I'm actually a general nurse by background. And I'm just going to talk to you about the work we've been doing around the annual physical health checks within the trust. So it's always key to remember why we're doing this. So why is it important that we focus on the physical health of people with serious mental illness? Well, you may well know that people with a serious mental illness die on average about 20 years younger than their peers in the general population of the things that people who live to the ripe old age die of. So these premature deaths are mainly due to things that are treatable or are preventable, things like cardiovascular disease, diabetes, alcoholic liver disease, and cancers. And we know, this is a huge health inequality, and we know that people with serious mental illness, they're likely to have higher alcohol consumption than the general population. They're 3 times more likely to smoke, so the impact that has on their risk of lung cancer and respiratory disease. They have double the risk of obesity and diabetes, usually linked to the medication. Antipsychotic medication tend to significantly increase appetite. They're 3 times the risk of having high blood pressure, partly due to weight gain and lifestyle, but also if they are drinkers, drinking alcohol to excess has an impact on the hormone that regulates your blood pressure. So the knock-on effect of that is high blood pressure, and that leads to a risk to further risk of heart disease as well. And also people with a serious mental illness have 5 times the risk of having abnormal lipids, so the fats within their blood. So again, that increases that risk of heart disease and strokes. So, a real sort of mixed bag of high risk factors there. So in order to address this, patients are entitled to an annual physical health check. So in secondary care mental health services, the physical health check is offered to those patients who are within a year of their diagnosis of a serious mental illness, or if they've been referred back into the services. So if they're over a year and stable, they might still be under CMHT, but the checks are done out in primary care. But if they have a period of instability or they've been discharged and they come back in, then we will offer them that health check again in the first year. And the health check involves their body mass index, so they have their height and weight recorded, conversation and advice around smoking, conversation around alcohol consumption. They have blood taken for glucose to check for diabetes, and also blood lipids to check for raised cholesterol. And they also have their blood pressure checked. And all these checks are done using the guidance in the what's called the Leicester tool. Probably a bit difficult to see that, but if you Googled Leicester tool, you would be able to see the detail here. So this is a cardiometabolic resource for people who've got a serious mental illness. It's really simple to follow. Basically, we want people in the green zone. The amber zone guides us what we need to do about it, and the red zone is that highlights that there's a problem. Because actually, if we don't intervene, there is no point in doing these health checks. There's no point in recording someone's blood pressure if you don't actually do anything about it, or if you know they smoke but you don't actually offer any advice. So it's a bit hard to see, but in the first column, green is stop smoking. So if you stop smoking completely, you're green. If red, that's a current smoker. And then in the amber, it talks about what we need to do. So brief interventions, referral for nicotine replacement therapy or group therapy, and referral to stop smoking services. And all the clinicians working within the physical health team are trained in brief interventions and the making every contact count training. So they really know how to have these conversations to help people make changes in their lifestyle. So how did we make all these improvements in physical health checks? So we used a quality improvement approach, which obviously, as you know, is well embedded within the trust. So we have got a physical health team in each division, one for the east, one for the west, which is a lead nurse and a senior support worker. So 2 staff in each. So we've used QI methodologies throughout. So A3 thinking, where we identified our problem, made our plan, all on one page. We did a lot of root cause analysis to find out what was the barriers to people getting their health checks. And then we used a fishbone to try and feed into this and see what was at the bottom of all of this. And a lot of the root cause analysis led us to a need to change the culture and to give parity between physical and mental health. we developed a really robust data tool, because we realised that unless you absolutely have got reliable, meaningful data, it's really hard to make improvements. So we've got a really good data tool now for identifying our patients. And we have regular improvement huddles. So for those who might not be familiar with them, our improvement huddle is where the whole team gets together, everybody can put forward ideas for improvement. And then we work through these and then we implement them if we feel that they would be appropriate. And some of our best improvement ideas have been quite small changes, and they've come from our senior support workers. So it does make sure that the whole team gets involved in what we want to do. And there might be something small that we can just implement as what we call a quick win. So we talk about it, we just do it straight away. Or it might be something that we want to improve that takes a bit more planning. So we'll do the sort of plan, do it, study it, act, you know, and do that cycle to make sure we get exactly what we want. So we've actually used that process for our new letters that go out to the GPs to make sure that they're fit for purpose. And we've actually involved some of the GPs in planning how these letters are done. So we've now got clinics in all 6 localities in across Berkshire. We don't have a clinic within Prospect Park Hospital. That was a conscious decision from some feedback from patients that often Prospect Park Hospital doesn't necessarily have good memories for people, in that it might have been a traumatic admission. They don't want to go back there for something that actually should be a positive move forward in their everyday lives. So we have for the Reading patients, we've got a clinic at within the university by the Talking Therapies building, and we are going to be opening the clinic at the Acre Resource Centre in Oxford Road, which would be a great location because so many of our SMI patients live in that area. They'll be able to walk, or there's free parking. So we're looking forward to opening that hopefully in the new year. And we also have a home visit offer, and we'll probably do a mixture of the two. We have quite a few home visits depending on the personal need. But the main reason I think for the success is the compassionate and tenacious approach of the team. When we first started doing this, we were going to have as a driver metric non-attendance, DNAs. We're not getting DNAs, which is absolutely fantastic. Whenever someone's not turned up, the team always ring them and talk to them, and there's always a really legitimate reason. It might be that they're really suspicious of us. You know, these patients who are quite unwell from their mental health point of view, so it might be that they're suspicious, they haven't got any transport, they might not want you in their house. Equally, they might not want to come to clinics. So they work really closely with the patients. I can give one example recently where my colleague spoke to a lady on the phone about 3 times. She was really anxious about coming out, going to new places, seeing new faces. So on one day, my colleague actually was out and about, so just knocked on the lady's door and just said, you know, I'm not coming in, just to say, I'm Deborah, I'm the person that's been phoning you about your health check, just so that you know my face. They had a quick chat on the doorstep. She found out what sort of coffee the lady liked. And actually about a week later, she did come in for her health check, and Deborah had made that coffee that she likes and had it on the table. So she felt really relaxed, and they had a really good engaging health check, and the lady had quite a few needs that needed addressing. So, you know, it's time consuming, but it actually, you know, this could help someone's mortality and morbidity in a really big way. So just to talk about how we're actually doing. So we started really good, reliable data collection on the 1st of June. And at that point, the trust performance is the dark blue line. So at that point, we were at 14% for all the elements of the physical health check as a trust. So the national target is 60%. So we set ourselves an interim target to get to 30% by September, but actually achieved that in the first month. We then reset the target to 50% by September, and we reached that in August. And I just quickly say, I think someone's unmuted. There's some bit of background noise. Thank you. So yeah, by August we'd reached 50%, and then that was sustained into September. So we reset the target at the beginning of September, which we'd originally set for the end of the financial year to meet the 60% as per the national guidance. We thought, well, we'll set that target straight away, and we actually achieved that at the beginning of October. So we've now exceeded the national target, and this slide is slightly updated on the one that's in your pack, in that I updated it this morning, and the current compliance is 71%. So 71% of our patients have had their annual physical health check. So it's a really fantastic achievement with those frontline clinicians who are so tenacious. They've carried on working throughout the pandemic, and I'm just really proud of the work that they've achieved for this group of patients. And then finally, to just get into the next one. So just to talk about the next step. So we want to improve our physical health offer. We've been approached by a physiotherapist in the trust who, as part of her PDP, wants to work with mental health patients from experienced health inequalities or in minority groups. So we're going to meet with her and see how we can improve the physical activity offered to our patients, perhaps through some home-based exercise programs, something like that. So that's meetings in a couple of weeks' time. We're collaborating really closely with Sport in Mind. You're probably aware of Sport in Mind. They're a charity who provide physical activity for people with mental health difficulties. They produce these wonderful journals where journaling is good for your mental health anyway, but the journal has just pages to write whatever people like. There's also some guidance around activities. They can keep an activity diary in there. And we always put the Sport in Mind timetable in the back. It also comes in a nice pack with pens, pencils, pencil sharpeners, which often our patients can't even afford to buy a pencil. So we've got some funding. These books are going to be arriving next week, and we're really excited to use those. And then we'll do a bit of an evaluation. We're also developing a physical health toolkit for our mental health practitioners. This isn't to set up all mental health practitioners to go around doing blood pressures and weighing people, because actually, as I said earlier, it's around the interventions that's important. What we want people to do is realise how important this is. So enabling their patients to get their checks and helping support them with those ongoing interventions, so conversations around smoking, etc., that kind of thing. We run ongoing educational events and bite-sized training. We've recently, in November, did a big event for ahead of Alcohol Awareness Week with a fabulous external speaker talking about the harms that come from alcohol. We opened it up trust-wide, CCG, people from the ICS, and also our colleagues at Royal Berkshire Hospital, and we had 622 people dialed into that meeting, so it had a really broad appeal. And we also want to improve access to physical health checks for those patients that are more than a year since diagnosis. So this should be done in primary care. We will do it. If a patient won't engage with their GP, we'll see them in our clinics. But what we really need to do is work with our care coordinators to make sure that they facilitate that patient going to their GP and having that health check. What we hope is that we can get them on that journey by seeing them in that first year, provide them with the information that they need. We give all our patients a physical health passport to record all their information, and that has all the local resource groups and third sector support organisations. So we give them that, but we want this to be a continued journey. So we need to work with our care coordinators to make sure that this is ongoing and it's not just a one-off in your first year having the health check. So that is a summary of what we do. I'll just unshare my screen now, and I'm happy to take any questions.
Thank you so much, Kerry. A really interesting presentation, and clearly a body of work that's making a big difference. Personally, I really love the attachment to QI, because it's that's a management or leadership tool that just keeps delivering. Lots of raised hands I can see. Alex, I'm going to go to you first, because I think you raised your hand first. Please go ahead.
Okay, thanks. But I think Paul did. But Paul, are you okay if I go first? Just say, Kerry, the 20-year headline of earlier mortality for patients with serious mental illness is just huge, isn't it? And we need to get that out more and more and more, so people understand this inequality that's happening for people with SMI. You answered my question about what do we do about greater than 1 year on caseload, and that partnership with primary care is going to be fundamental going forward with the care coordinators. I just wonder how we build that joint kind of health coaching responsibility with the individual with an SMI and with primary care, because we can do the health checks and we can do them in the first year, we can do them ongoing, but how do we get into that health improvement with the individual once that baseline's been done and it's shown they've got some risk, because it's likely to.
Yes, and it is a challenge, isn't it, knowing how to keep this momentum going. And when the service was set up, you know, our model is that we did the annual physical health check and then we handed them over to their GP for ongoing interventions. But we're realising now, actually, it's all a bit too much, maybe in one appointment, to try and get people on that sort of that change journey. So we're going to start implementing a follow-up appointment about 2 to 3 months down the line to see how people are getting on, and to reiterate some of the advice or introduce some advice that wasn't appropriate at the time. We're also, as far as possible now, we'll do the physical health check with the care coordinator, so that the care coordinator can carry on with that information and, you know, guidance. We're trying to do some bite-sized training with the care coordinators to keep them, you know, on the journey and realising how important this is. And then we've also got now regular meetings with our CCG colleagues, and we're starting to think about how we can interact a bit more to keep this as a, you know, a rolling journey for the patients. We don't want people to just come, have their health check. You know, otherwise you'll get, I hear of people who've got diabetes, they know that when they have their blood done, it monitors, it tells them what they've been like for the last 3 months. So they just don't eat any sugar for 3 months and then go mad for the rest of the 9 months of the year. So, you know, it is tricky how we keep that engagement. And I think these community groups, things like Sport in Mind, one of the things we're talking to Sport in Mind about is whether they would think about putting on some sort of groups around healthy eating. Hate the word diet, I think it puts people off, but it's about eating well and being healthy and just trying to engage people like that.
Brilliant. You're building a fantastic network of support that these people just haven't had. So it's, you know, it's very, very exciting to make that kind of impact and straight off. You know,
and I always
people.
start every presentation with that, why we're doing it, because I think we need to keep going back to that inequality of 20 years. And people make an assumption in mental health, it's about self-harm, and actually it isn't.
Thank you, Alex. Paul, over to you.
Yes, thanks, Kerry. That was a great presentation, very optimistic and clear, except for one thing for me. You talked about percentages, and I'm not sure what the percentage is of. We know that you're focusing on the community and not hospitals like Prospect Park, but are you focusing on all the caseload of community mental health teams or a subset? And if it's a subset, how big is that subset?
Yeah, so it's a subset. It's people who have got a serious mental illness diagnosis. So there's various, the READ codes that identify people with a serious mental illness, and we match those with the ones that are used in primary care. So they're mainly the psychotic type illnesses, because that's where the biggest risk is because of the side effects of the medication. So they are people that have got the SMI diagnosis, and it's less than a year since they've come into the community mental health team or they've been referred back in. So it's a subset of obviously that number fluctuates, but it's around about 280 to 300 patients are on the cohort at any one time. But of course, every day, some people get discharged, go past the 1 year, and new people come in. The number of referrals in can hugely vary. Some weeks it might be 1 or 2. 1 week we had 16 referrals. So we know we'll never get to 100% because there's always new people coming on and going off. But yeah, it is a subset, and it's community mental health patients.
Okay, that's great.
Yeah.
That makes it clear. Thank you very much.
Verity, can I go to you next?
Yeah. First, this is great. I mean, people who've known me for a while have known this has been one of my topics. The fact that, to put it bluntly, I've lost so many friends over the years who have died 10 or 20 years earlier than they should have done. This is great. obviously the measure of how successful it is will be if people are living longer, and also if people are living happier lives. And be great to see those statistics hopefully roll out and show real improvement in people's length of life and quality of life over years. But I do have one thing that niggles at me, which isn't a thing for the trust because it's beyond your control, but I'm well aware that there are other factors beyond healthcare that affect people's quality of life. And it's great that the trust is doing this and hopefully improving people's physical health. But actually, sometimes people make what appear to be very bad choices because lots of the rest of their life is so miserable. If you're living in poor housing, if you've got no chance of getting a job, then it's tempting to have another drink. And it's a pity that can't actually get somebody beyond the trust in government to actually look at joining up the entire thing and making it easier for people to have better lives in general. But yeah, great work, and I'll be really interested to see, you know, the outcomes and hopefully, as I said, that improved quality of life and length of life rolling out for people.
Yeah, and we do know that SMI, of all the long-term conditions, it's SMI, that serious mental illness, that has the biggest impact on people's employment. So that's the sort of biggest cohort. But we do link in with our employment service to try and you know, help get people into employment. But you know, hopefully by improving physical health, that might get people in a better position in terms of their employment. But yeah, there are many other factors, not just, you know, not just this.
Yeah, and a final
well identified, Verity.
Yeah,
I'm going to move on. There's still lots of questions. Ross, can I go to you next?
Can I just a final quick thought before we move on?
Please go ahead.
It'd be great to actually see. It's great that you're tackling this for the cohort with serious mental illness. It'd be great if some of this learning could then be passed out to GPs for people who've still got, you know, major impacts on their mental health from other mental health issues.
Thank you for that, Verity. Ross, can we go to you next?
Okay, thanks very much. Thanks, Kerry. It was a very interesting presentation and good to hear more details. And as a trustee of Sport in Mind, it was great to hear about the collaboration. Couple of quick points. I appreciate that a lot of the things you're focusing on, like cardiovascular disease, etc., are really important. But one of the areas where people with mental illnesses miss out on is dental care. Does that get considered at all?
It's not part of the physical health check at the moment, but my understanding, I think I have read, that coming into the physical health check in the future will be dental and sexual health. Having said that, so the parameters I've talked about are the ones that are the standard physical health checks. However, my team do talk to people about other aspects of their health. It's kind of a bit of a general talk. But yeah, certainly I have read that may be, I think it was one of the GP meetings saying that they were anticipating that dental and sexual health would come in, so yeah, really important point.
Yeah, that would be helpful. And the other quick point is you mentioned about obesity and often that's a result of medication. Is there any thought of working more closely with clinicians and pharmacists to look at, you know, potential alternatives, because it's a big issue for people taking meds that, you know, the end result is they put on a lot of weight, which often makes them feel worse about themselves, doesn't contribute to their mental health, but also doesn't help their physical health. So just again, you know, as you talked about a more joined up approach with other areas.
Yeah, and we do get some support from, it's actually one of the pharmaceutical companies but she's very good at doing sort of general, not plugging their products. talks around the best alternatives. I mean, unfortunately, majority of the antipsychotics do cause weight gain. And I think what we feel is really important is that we need to get in there right at the start. And regardless of what someone's BMI is, we still have the conversation about healthy eating and the risks associated with their medication. And there's evidence that shows that people of a normal weight and BMI are at risk of the greatest percentage weight increase. They, put on even more weight than somebody who is already overweight when they start on these medications. So, it's a real difficult balance, isn't it? That you don't want someone to be psychotic, but equally you don't want them to then end up putting on lots of weight and at risk. So, as part of the ongoing educational programs, we do talk about medication and, making that balanced choice.
Okay, thanks very much.
Thank you, Ross. It's very clear that we can't do this alone in its entirety. No. Andrew, I know you need to leave in just a few minutes, so please go ahead.
Thank you. I think it's wonderful that you're doing this work by identifying these people and advising them. But are you getting into therapy? Because treating someone with an alcohol problem or smoking problem is quite a long and slow and difficult process, and even more so if they've got a psychotic illness. So
we are more referring and signposting onwards. So we're not a service that offers long-term support for alcohol reduction, smoking cessation, but the teams are really well versed with the support that is around in the community. So we refer on. We also all the patients that we see, I mean, most of the time we're trying to see them with their care coordinator, but there's certainly a discussion that goes on with their care coordinator and their consultant psychiatrists, and a comprehensive letter goes out to their GP that sort of sets out any actions that we want the GP to take. So, but it's more it's starting that conversation and then putting them in touch with the right services rather than offering our own smoking cessation alcohol service.
Thank you.
Thank you, Andrew. Tom, and then John, and then June.
Yeah,
then I'm putting this on.
Thank you. That was really encouraging. And my question is actually for the executives, and because it's about commissioning of all this. It sounds like we've got a great service, a properly resourced service here. Yet, for inpatients, quarter after quarter and year after year, we have failed to meet targets on doing physical health checks on inpatients at Prospect Park. And I'd like to know who makes it. It seemed to be a funding matter. Just are you going to appoint somebody to do them? But so how are these decisions made? And then on the wider scale, at the commissioner's level, if I was a GP, I'd say, how come Berkshire Healthcare's got all this money to set up a lovely service? Sounds really great, and I'm run off my feet. And I think at the commissioner's level, I'd say, if we're not integrating this with primary care, and it's got to continue in primary care, hasn't it? It's got to go on in primary care eventually. How are we going to we're just undermining primary care if we carry on like this. So that's my question really for the execs. But thank you very much. It's been very enjoyable and optimistic.
I can respond to the Prospect Park points straight off, and Kerry, correct me if I'm wrong here, but I think in terms of physical health support to the short-term acute need of patients within Prospect Park, support is available there. But going to Kerry's original point, this is about living with a serious mental illness in the community and providing physical health checks and partnership with primary care to support. I think Kerry covered off that doing physical health checks at Prospect for community mental health patients wasn't right. Kerry, in terms of your physical health experience around Prospect, what's the kind of clinical view of doing physical health checks whilst patients are inpatients, which by its nature should be a short-term intervention?
Yeah, so the patients do have a physical health check whilst they're inpatients, but I think we're just working through how that's recorded. So that we can have a bit more visibility about that. So there is a physical health lead based in Prospect Park who does do the, they do have a physical health check, but equally when the patients come out of Prospect Park, go into the CMHT, we will then pick them up. So if there's any elements missing, or even we'll make an appointment just to reiterate the interventions to get them, they might have had their numbers done, so to speak, but it's about getting them on that journey of interventions. And in terms of primary care, I work really closely with primary care, and I meet with the mental health leads in the East and West CCGs on a regular basis to make sure that we are collaborating and we're not each doing, we've all agreed that if a patient tips up in front of you and needs a health check, we'll do it, because some people won't go to the GP, some people won't come to us. But we know equally that we need to focus on the 1 year, they need to focus on the beyond 1 year. We're really working on how our systems link up. We use Connected Care. GPs they've got a new version of Connected Care coming, so they'll be able to see on Connected Care exactly what we've done, so it will work both ways. So, we are working really closely together and sharing training, etc. So, I do feel that's a good relationship that we've built.
Thank you.
John, thanks for your patience. Go ahead.
That's right. You've actually answered some of my points just there in the answer to communication with the GPs and stuff, because obviously this is going to be the key. I agree from personal experience that when you're discharged on antipsychotics, it's quite interesting. But I was, I think, fortunate that my psychiatrist was able to wean me off those relatively quickly on discharge. But GP capacity is always going to be the issue here, as we all know. I think from personal experience of my partner, my local GP is way behind on diabetes annual checks. I mean, I think she had one this week, which is the first one she'd had for 2 years. So another sort of check for them. We're going to be into this capacity issue with the GP nursing staff to do it, and I don't know where we go with that. Hopefully ICS will help, but they're not going to suddenly magic more people when we get the ICS. But so hopefully it's going to be useful. Well, obviously what you're doing is fantastic, but as you quite rightly said, it's where you go beyond that, and those people are continuing in the community with the serious illness and on that antipsychotic medication, that the issues potentially come back, because obviously we want to prevent them going back to Prospect. That's the whole point.
So I know that at least sort of probably 4 or 5 years there's been sequins and QOF for primary care around these physical health checks. They've actually been doing them longer than we have, and of course a lot of the patients that are needing this done in primary care are no longer under secondary mental health services anyway, so we wouldn't be in a position to be doing them. So we hope in a way that we can complement each other in how we're doing it.
June, you still have a question?
Yeah, sorry, my mute wouldn't come off. Sorry, Naomi. Actually, looking at the list, and because last to come to me, most of the questions I had on my list to ask have already been asked and answered. But I just did really want to pay tribute to Kerry. Kerry, I know this has been a topic of yours for a very long time, and you've made fantastic progress. And I just want to reinforce that this has been something in partnership with our GP colleagues over a number of years. They are funded, Tom, to do physical health checks. I think, like all of us, they'll struggle with priorities, and that priority is going to become under further struggle with the new vaccination pressures that'll be under in January. So I think for me, it's about making sure, Kerry, that we get the appropriate support from all partners. And the note that Alex put in the chat was a really good one. This is a responsibility of many, and if we work in consort with each other, we'll make sure that people get the best care. This is not a burden that BHFT should be carrying on its own.
Excellent point, June. Thank you. Last question, I think, from Graham.
Not a question. I was just going to comment on one aspect that raised, just to say that that's the West Berks executive site. I presented a paper that was signed off a couple of weeks ago, So there's going to be a new drug and alcohol behaviour contract from next April, which looks very interesting because it brings a whole load of strands that we currently had disparate. So it brings children and adults together, does some online stuff, does a lot of community work. So watch this space for the announcements on that. I can't say how much it's costing, and I can't say who it's been awarded to because we haven't actually done the contract yet. But it will, I think, be an improvement on what we've got at the moment.
That's good to hear.
Thank you, Graham. A really rich presentation, Kerry, and thank you. Not just the presentation.
Naomi, I think you've got another couple of questions. I've got my hand up too.
Sorry. Isabel, go ahead.
Thank you very much. Thank you, Kerry, very much for a very interesting presentation. It's really just 2 points of interest which you might like to know about. Interestingly, dentists came up. Are you aware that some dentists, when you haven't been to the dentist for 2 years, that has been very difficult for some people recently, as you know, they are actually taking them off the list. They did that to a friend of mine, and she said, when can I get back on the list? Oh, it'll take a year. So she had to go and find another dentist. As you know, dental problems can have enormous effect on people. The other thing, and talking about people who are unsteady on their feet when they haven't been out so very much, 2 of my friends have actually had chairlifts fitted in their homes. They now are both using walking sticks. So that's actually been detrimental to them in a way, just so that you are aware of that. But thank you so much for all your information. It was really well worth listening to and learning about. Thank you.
Thank you.
Thank you, Isabel. Am I missing any other questions? That's great. Thank you for that, Julie. I'm going to move us on to the next presentation and really appreciate it, Kerry. It's an enormous topic, actually, and is going to require a coalition of many, to make a big dent. But we are making an extremely big fist out of this, and much thanks to your good self. On to the next presentation, which is from Marie Evans, our Clinical Director on Neurodiversity.
Hi everybody, good morning. Yeah, my name's Mary Evans. I'm the Clinical Director for Children, Young People and Families and the Eating Disorders Service, but I'm also the Trust Neurodiversity Lead, leading on a strategy that we're developing at the moment. So thank you very much for spending the time to listen to me this morning. And I've got to say it's a really tough act to follow as well, coming after Kerry's presentation. I wish I'd gone first. But I think what you'll see is there are some similarities in the reasoning for why we're doing the work that we're doing around neurodiversity and some of the work that Kerry's talking about. And I think actually some of the people Kerry's talking about are the people that I'm talking about as well. So you'll see some crossover. Also, apologies if you can hear rumbling in the background, but my garden office is next door to my neighbour's garden work shed. And he's currently working on either an aeroplane he's building, because he's very clever, or a motorbike. So if you can hear rumbling in the background, I do apologise. Right, I'm going to share my screen with you. Hopefully that will show. Right. So, yeah, he's revving the engine right now. You should hear it. So in April this year, Berkshire Healthcare made a commitment to develop a neurodiversity strategy across the trust. And that included the appointment of myself as neurodiversity lead as well, to give time to leading the monthly steering group and building on our strategy. It focuses on the care and treatment of people of all ages who access all of our services across the trust. And at the moment, it's focusing on mostly autism and ADHD, but there's an acknowledgement that there are other neurodiversity things to consider, such as Tourette's and dyslexia, processing difficulties. But our hope is if we focus on autism and ADHD, we can kind of start to build more awareness generally. In addition to looking at the people who use our services, we're also thinking about our workforce. So we also have a neurodivergent workforce. So we have people who are autistic who work for us in all number of parts of our trust. And we have people who also access our services who work for us as well. So the strategy is kind of considering both those things. I met with Martin a little while ago to talk about the strategy, and he suggested it would be helpful if I just gave a brief description of autism and ADHD and also neurodiversity. So I've popped this on a slide for you. So neurodiversity refers to the diversity of human brains. So it's the understanding that we're all different, really. And it takes the approach that there isn't one right or one normal way for the brain to work, and that there are many diversities in the way that we all see and interact with the world. And there's an acknowledgement that neurodivergent people have a lot of strengths, as well as a lot of social barriers and inequalities. And it's those inequalities that we want to kind of set right within this strategy. Autism refers to a diagnostic code, really, within our DSM and ICD diagnostic manuals. So to get a diagnosis of autism, there's an acknowledgement that there are difficulties or challenges around social communication. So that's things like reciprocity, non-verbal communication, and developing and maintaining relationships. And then also restricted behaviours. So that might be stereotyped behaviours, insistence on sameness, maybe fixated or what seems to other people to be unusual interests. And then also things around sensory processing, so hyper or hyperactivity to sensory input. And historically as well, it's important just to note that there's been a male bias in the identification and the diagnosis of autism as well. So we've got lots of women and girls being missed or misdiagnosed. And you'll also see in the news at the moment around adult females getting diagnosed as well, because we've had some famous people such as Melanie Sykes recently being diagnosed with autism. So it's hit the headlines again. ADHD is attention deficit and hyperactivity disorder. So this refers diagnostically to inattentiveness, so a short attention span and difficulty concentrating or difficulty focusing. Hyperactivity, so the need for movement all the time, and impulsivity, so acting and without thinking, and that has to be present across all contexts as well. So for young people, for example, that would happen at school but also at home. I think one of the things we really want to get across is that autism and ADHD is everybody's business. It's not just the job of our autism assessment services or our ADHD assessment services and treatment services. There's about 2% of the population that we know are autistic. There's around the same that we know have ADHD, and there are going to be a number of people who never get a diagnosis, or as we've sort of picked up in the news at the moment, people who get diagnosed as adults. So all our services work with people who are neurodivergent, not just our autism and ADHD services. That will be dentistry. So somebody mentioned dentistry earlier. So our dentists need to be aware of autism and ADHD. Podiatry, if you think about sensory processing and having somebody touching your feet, it's really important that somebody's aware of how that might be experienced by someone who's autistic. West Call, physiotherapy, and our mental health services. We know, though, that the prevalence of autism and ADHD in our mental health services is higher than that of the national average of people. So a bit like Kerry, setting the context of why it's important that we do this. Like our people with diagnosed mental illness, people who are autistic have been found to have an overall risk of early mortality that's much greater than the general population. So it's double that of the general population. And they're at risk of dying younger for physical health reasons and mental health reasons. So again, with a nod to Kerry's presentation, that shows why her work is so important. Autistic people who don't have a learning disability are 9 times more likely to die by suicide than those who don't have autism. And multiple studies have suggested that between 30 and 40% of autistic people have considered suicide. And children, around 14% of autistic children have considered suicide, compared to 0.5% of typically developing children. So that's a huge difference. With learning disabilities, I think you're likely to die around 30 years younger as well, so it's an even bigger gap. We did a review of serious incidents across the Trust over 5 years, looking at suicides of young people aged between 17 and 25. And we found that 11 of those people either had a diagnosis of autism and ADHD or were suspected of having a diagnosis. So that's 50%, so that's a huge difference, again, if you think about the general population. And we just know that people with ADHD are at an increased risk of experiencing depression or anxiety symptoms. So there's lots of reasons why we need to get things right. And looking at the numbers of people who are accessing Berkshire Healthcare services, over 5,000 show on RIO as having a diagnosis of either autism or ADHD. And those are just the people with a diagnosis. So we know there are going to be lots of people using our services that maybe are suspected of being autistic or having ADHD, or people haven't even considered it yet. It's gone missed or misdiagnosed. Of the people we do know, the biggest percentages are in the males aged between 12 and 25, so 27.65% up to 17, and over 20% of young people aged between 18 and 25. So again, much higher than that 2% of the population. And for females, again, we know they're less likely to get a diagnosis, but for girls aged 12 to 17, it's 12%. And for females aged 18 to 25, it's 7%. So again, it's higher than that national average of people. So we have a vision for our strategy, and our vision is for everyone in Berkshire Healthcare to recognise, understand and celebrate neurodiversity, and for all neurodivergent people working in or using our services to be empowered and enabled to have equal access to effective services, support and fulfilling lives. And actually, it really touched me when Kerry was saying about her colleague who went and knocked on the door of somebody so they could see what she looked like, and what good practice that might be for somebody who was autistic, for example, who would be struggling to come in for a health check. So we've got four kind of main arms to our strategy at the moment. And similarly to Kerry, we're using QI principles with a lot of the work that we're doing. So we want to co-produce our strategy with experts by experience. And we want to do that by paying them and rewarding them for their time. We don't want just to expect people to give their time for free, really. So we are, at the moment, we're doing some job descriptions and matching for an advert to go out for people to join an expert by experience board so they can work alongside us as we develop the strategy further. We want to improve knowledge and awareness about neurodivergence across all of Berkshire Healthcare. So we've recently been part of a pilot that was run alongside the National Autistic Society, delivering what's known as Oliver McGowan training around autism. Oliver McGowan is a young man who sadly died due to an extreme reaction to antipsychotic medication. And there were kind of big issues there around communication with him and with his family about how he'd reacted to that medication in the past. We're looking at identifying training needs for all staff and adapting all of our current training as well. And that includes training around suicide and suicide prevention. So our suicide prevention group are actually doing some targeted training around autism and suicide prevention. We want to improve the quality and access of services for neurodivergent people and their families. So we have a project group identified to work on this. That's starting with a data review, so who's using which services and when, so getting an idea of how many people are accessing Berkshire Healthcare who are neurodivergent. And we're just in the process at the moment of completing an experience of service survey to go out to the public to get feedback from people using our services about how they've experienced it. And we've already done some work around what are the kind of things that's important for us to ask about in that survey. So the survey itself has been informed by the public before we actually send it out. And we're doing some targeted work around our community mental health service about what happens when people who are referred to us, who are autistic or who have ADHD and a mental illness come to our service. How do they then experience the kind of referral on from our common point of entry into our community mental health teams? And we have a workforce group, and that's about making Berkshire Healthcare a great place for neurodivergent people to work. We've got a neurodivergent workforce, and there's a potential neurodivergent workforce out there. So we want to identify any barriers to people disclosing that they're neurodivergent and, you know, getting support within their work role, and also think about what we can do to attract people to come and work for us. We have a staff survey that's due to go out very soon. And we're going to do an executive briefing. It says December there, but we're going to do that in January now. And we're just in the process of building some neurodiversity badges and pin badges to go out for people to wear to show their support across the trust as well. So I think that's where we're up to. I'll stop sharing with you.
Thank you.
Any questions?
Mary? Another very insightful and important piece of work. I've got an echo, forgive me. Verity, I'm going to go to you first. Please go ahead.
Hi, yeah, really. Oh, sorry, I'm getting lots of echoes here. Somebody got. Ah, that's better. Yeah, another really good presentation and excellent work. And it's great to see that the Trust is really looking at this and hopefully use it to achieve better outcomes for people and also better outcomes for staff. And also it's really interesting, I mean, given the pressures that there are on recruitment of staff, yeah, there's a potential great pool of workers out there that if the Trust can be made to work for them, they can actually be good workers for the Trust. Need to declare an interest here. I mean, I was actually diagnosed well into adult life with dyspraxia. And I've got to say, once I got that diagnosis, it was the start of my journey of recovery from depression, because a lot of the stuff that hadn't made sense before started to make sense. So, you know, it can really actually, being aware of people's neurodiversity, the advantages and the difficulties it can produce, can actually help people to make real recoveries. So great work.
Thank you. Thank you.
Thank you, Verity, particularly for your personal insight there. Paul.
Hi, this is very interesting for me, and I'd just like somehow to get your email address, and then I can contact you about someone I think who can contribute to your project.
Absolutely. Shall I put it in the chat for the meeting?
Yes, or if it can go in the so the chat's probably a good idea. Yeah.
Okay.
Thank you.
Thank you, Paul. June, and then Tom.
Thank you. Mary, first of all, thank you for demystifying some of it. You know, I spend quite a lot of time with the services on ASD and ADHD. To bring it down to a language that I can relate to was really, really helpful, I think. One of the things that you said that resonated with me is that, you know, how important it was for other services that people may be accessing who identify with ASD or ADHD, and I don't know if that's the right language, forgive me if it's not. But they haven't got that recorded diagnosis within our system. How do those other services like podiatry, etc., look for signs that they may need to interface with that patient slightly differently? And are we going to give them some training to help them do that?
I think in some respects, what's good practice for people who are neurodivergent is good practice for everybody. So some of it will be bringing stuff into practice that everybody, for example, around podiatry, it might be talking to people about their sensitivities around their feet. You don't have to know whether they're autistic or not, but you can ask stuff around sensory processing that might help that process. Or if we start to think about our environment, so strip lighting and sound and noise and all the things that can cause distress for someone who's autistic or who has issues around sensory processing, if we address those anyway, it will probably help everybody. An example is the quiet time that they have in some supermarkets for people who are autistic. So it's meant to help people who are autistic go into the shop. I would guess that there are a lot of people who aren't autistic that would quite like to go into the shop when it's quieter and it doesn't have that really annoying music and stuff. So I think some of it will be about, good practice for all, actually, as well as some of the other stuff around communication and understanding and things like that that will need to go alongside it.
Thanks, Mary.
Tom.
So first, just a couple of things. Firstly, just a bit of understanding. If people have not acquired language, they don't have language. Would you say they necessarily have a learning disability, or is that part of certain cases of autism? But that's just a question. So a question in understanding. Perhaps I'm behind the times and so on. And the second thing is, do you think? I mean, I've just anecdotally seeing people. Do you think people sometimes are brought in under section incorrectly, and autistic behaviour is sometimes misdiagnosed as misunderstood as some other mental illness? Does that happen? I mean, I feel I might have seen that happen, but I wonder if you think it really does happen and what we should be doing.
Yeah, I mean, I think there are lots of misdiagnoses of people who are autistic who haven't had the support they might need or the understanding that they might need, and then behaviours have escalated because of a lack of support, and then they've been interpreted under a mental health label, or they've then developed a mental illness because things haven't been put in the right place for them early on. So there's probably a mixture of both, Tom, actually, I would suspect.
So what do we do about that?
And some of that is going to be about awareness, I think, and people understanding autism better. I think the more, for example, people who sometimes get a diagnosis of borderline personality disorder, underneath there can be an unidentified autism. So the more we understand, the more we can pick things up at the right time and interact with people in the right way and give them the right support, rather than a label that maybe doesn't help them and leads them down a different path.
Thank you, Mary. A couple of really amazing presentations, some really deep insights into some cold faces that the Trust is taking extremely seriously and driving some quality results. I'm going to go to our next agenda item, which is the annual Audit Committee report, and hand over to my fellow Ned, Rajiv Gaffer. Rajiv, I know you don't need any teeing up from me on this, but I just wondering if everybody in the room has kind of met you, so you might want to just do a sort of 30-second intro on your good self and kind of where you come from and how you came to be part of the BHFT team.
Thanks, Naomi. Good morning, everyone. So as Naomi said, I'm relatively new to the Trust Board. If you expected to see Chris Fisher here, then sorry to disappoint. I will try my best to be an adequate replacement. So yes, I joined the Trust on the 1st of October. I am a qualified accountant, chartered accountant by trade. I spent the first few years of my working life with Deloitte, doing external audit for mainly information technology companies in this area, in the Thames Valley corridor. And then once I left the accountancy practice, most of my career has been in IT, large IT companies. Most recently, I worked for a company called Cisco, who develop networking and other information technology equipment. So I do have a full-time job in addition to this role here. I was contacted by the recruitment company who were looking for the replacement for Chris back in April. I had just finished a course with Deloitte around the role of NEDs and how we could address the recommendations of the Parker Review Committee a bit better. So I was aware of the workings of boards and NEDs, and that's piqued my interest. I think I met some of you during the interview process, and I mentioned that my father was an anaesthetist with the NHS for 30+ years, working at Heatherwood Hospital, and I grew up in this area. So that's a little bit of background on myself. This is a slightly strange situation for me to be in, because this is the report of the working of the audit committee for the last 12 months, and I clearly have only been part of that committee for the last 2 months. So I'm going to rely heavily on Naomi and Alex and Julie to help me with any detailed questions that you may have. But I do want to say my initial impressions of the trust and the board have been extremely positive. I can already see that the quality of the executive team here is very, very strong, as is the depth and breadth of experience of my fellow non-execs, including Naomi. I think the governance framework that I've seen seems very comprehensive and sound, and clearly I look forward to working more closely with all of the team in my term here. But if we go on to the actual report, I'm going to assume we've all read the report, which is on pages 17 to 45 of the pack, so I won't go through that in detail, but I will just make a few comments and then we can open it up to see if there are any questions. I think it's always important to look at the terms of reference, and the terms of reference haven't changed in the last 12 months, and they are on page 26 onwards. They state that the committee should meet 4 times a year. We actually met 5 times this year in 2021 rather than usual 4. There was an additional meeting in May where the annual accounts were presented and approved. The membership of the committee, you'll know that the audit committee has non-exec and exec directors and 3 external advisors. So our external auditors, which are now E&Y, having replaced Deloitte during the year, our internal auditors, RSM, Risk Assurance Services, and then TIAA, who provide us with counter-fraud services. In terms of the external audit, I understand that Deloitte's attended the September council meeting and presented their audit report, gave an unqualified opinion on the trust accounts, and then we then approved the charity accounts at the last audit committee meeting in October. And then the internal audit report, the annual report for 2021 is attached in the pack. I think it's starting on page 33. And what was, I at least found very useful, Appendix C on page 43 was useful in explaining the terminology. So you'll see that the highest level of assurance the internal auditors give is substantial assurance. And in their words, that means the controls in that area are suitably designed, consistently applied, and effective. And then the next highest level would be reasonable assurance, which also means that the controls are suitably designed, consistently applied, and effective. But there were some improvement areas that were agreed with actions from management. And I mentioned both of those 2 things because you'll see for that year, there were 3 areas where RSM gave substantial assurance and 4 areas where they gave reasonable assurance, and there were some management actions. And it's part of the audit committee's remit to ensure that the action areas agreed with management are being addressed in a timely manner. And we review overdue actions at each audit committee meeting, and I have to report to you that there was no issues to note on that front currently. And then just before we pause for any questions, I just want to state that, as it says in the pack, there are no substantial issues or concerns that need to be brought to the council attention with from the work of the audit committee during 2021. And with that, I'll pause and see what questions we have. Raymond, I think you mentioned very early on in the meeting that you had a question.
It's not a question, Rajiv. It's actually congratulations. I like yourself, I come from an IT background, although I'm on the technical side, and I just wanted to commend the audit committee for and the trust for the IT project management receiving substantial assurance, because as you and I both well know, that that's not a trivial achievement in the world of IT and also in the world of public sector. So congratulations to the trust, and I think that should be minuted and passed up the chain.
Thank you so much. I would echo that.
Thank you for that, Raymond. Paul.
Yes, thanks for the report. I just want to state a couple of things which I think I state every other year, actually. This is a very important report for the governors because it gives us an insight into what the non-executives are doing in relation to holding the trust to account. And for that reason, my opinion is it's not enough to say everything's all right. What we as governors, or what I as a governor want to see, is some comments along the lines of, well, for example, the two subjects here in relation to quality improvement program and EUPD pathway projects. It's important that the audit committee, I believe, does challenge the trust on issues like these projects, which don't seem to have delivered exactly as they we hoped they would deliver, or haven't actually measured the results, which is quite important for me. I think, you know, the QI program, governors believe that is extremely important. It's extremely important for staff to have this quality view of their job and take responsibility for their job. But equally, it's important that the trust measures the benefits of this. And so I think the audit committee rightly takes some responsibility in this area and reports to governors. One of the items here, we've got data quality assurance, and it's very good for governors to feel that the audit committee is looking at this as an issue, but it doesn't give any clear view about what is being measured, what is being reviewed, what the progress is of the trust in improving their data quality. So I think while this report is good, it could be better, and it could refocus a bit more on not what the audit committee's responsibilities are, but what the actual audit committee is doing and what it's pushing back to the trust for further information or further activity, further action. Thank you.
So we can certainly take that, Julie, as an action to think about how we improve the report going forward.
Thank you for that, Roger. And Paul, as usual, you raise 2 or 3 really important issues there, and it really is about the role of the audit committee and, you know, how good we are in terms of our performance. And I like the way that you teased out QI, EUPD, and data quality assurance in particular. I think my response would be, you know, where's the evidence that demonstrates to you as governors that we as audit committee, particularly the NEDs that sit on the audit committee, are driving hard to hold the executive to account in respect of those, not just those 3, but, you know, the entire remit of audit committee. And the evidence resides, I think, in a number of places. First and foremost, you know, those are topics that have, you know, we have been relentless at board level in ensuring that those topics continuously come back and we ask the right questions. And if we're dissatisfied with, you know, being able to see data and information and a well-articulated report that shows that performance is indeed as we would expect it, then we just keep going. I would say that particularly as far as QI and EUPD is concerned, it's true that, and Alex, I'm going to look to you to kind of, you know, add some colour here or adjust the tone. In particular, those 2 areas, it's true to say that the pandemic has had an effect in terms of, you know, the pace at which we have been able to see progress. And perhaps that's what we would expect. But certainly from my perspective, the way in which we just take the approach, which if we're not satisfied, we just keep going. And the executive eventually, not eventually, they understand that and they get to it. But Alex, any comments you want to make in that regard?
Yeah, I think that's fair, Naomi. On the QI programme, Julie's just put in the chat that we are due to bring a QI programme report, including benefits, to the January Audit Committee. So there will be specific insight and review there that comes through that meeting. EUPD, I suppose I would colour this by saying we were hopeful that an address of services for people with personality disorders would really strongly support the flow pressures that we were seeing and bed occupancy that we were seeing in Prospect Park. It is one part of the answer, and we have put in the services that we were due to put in, and there is a much better support to people with personality disorders in the community now, but it is not the only issue affecting our flow and occupancy at Prospect Park. So I think that would be one of the benefits that has not come through as strongly as it might have, but we have done the right thing for people with personality disorders. I think the other thing about this report is it's a summary of the work of the Audit Committee, and it's always difficult to achieve the right balance within these kinds of reports. But from my perspective as an executive, we are absolutely getting the challenge and scrutiny that we should be getting on these really important topics in Audit Committee. But as Raju said, he'll take away those comments. Hope that helps.
Thank you.
Thank you, Paul. Tom, over to you.
Thank you. It was an interesting report. Thank you. It's just a sort of minor question. I see that the internal auditors claim that they provide benchmarking information, and I wonder if the Audit Committee uses, if it's good enough to use, and whether there's any outcome from it. I mean, we've never seen anything, I think, although we do often hear individual comparisons on particular features, we've never sort of seen general benchmarking overview or so on, I think.
Rajiv, may I just come in there? So
yes, please.
On the head of internal audit opinion, there are benchmarks on key drivers around our financials, around where we position within certain key non-financial audit reviews, and in the regular updates to Audit Committee, there's benchmarking information in their routine updating around the sector and around their clients. That's the kind of benchmarking that's being talked about and is available to Audit Committee to test and check where we're sitting on various topics.
I have another question, but in relation to these benchmarks, are they internal or external?
They're external.
They're external, so it's across the whole nation. So we really are looking at the right.
It's usually across RSM for internal audit, RSM's client base, and similar trust types nationally.
Thank you.
Thank you. Any further questions?
Yes, I want to reinforce what Paul was saying, and I'm sure that Raymond and Rajiv will agree that many IT projects fail because of poor specification. And one of the aspects of poor specification is there are no criteria in there that you have actually delivered what any phase in the project says it's going to deliver. And for coming from an academic background where we spent a lot of effort putting together our marking script, this is an absolutely crucial part of it. And I think it does reinforce what Paul was saying, so that we can all understand exactly what's being measured, how it's being measured, and that we are actually able to deliver what we said we were going to deliver.
Yeah, we'll take that comment on board. Thank you.
Thank you, John. Thank you, Rajiv. You survived.
I did.
Good. Thank you, team. Let's go on to the next item on the agenda, which is our committee and steering groups. And we have 3 reports there. And Paul, I think you're going to lead us through that. Is that right?
I've been asked to talk for the quality group, but I don't think there's a lot to say. There's a little report produced by Andrew Horn, if he's no longer here. We had a meeting, was it last week or the week before? And our special contributor was Minu Irani, who talked about the death in the trust. And it's sort of interesting for us for those who like numbers, you know, we have about 60 serious complaints a quarter. We have about 4,000 deaths a year, which was a number I'd never come across before. We were very happy to learn the detail from his presentation. I think we also, not mentioned here, we looked at the terms of reference and agreed the terms of reference didn't need changing, so we haven't brought those to this meeting for renewal, official approval. But otherwise, if there's any questions, please fire away, and if I can't answer, I'll get Andrew to email a response to you. John.
Thank you, Paul. John, yes, go ahead.
Yeah, Paul. Unless I'm mistaken, I thought that we had to get council approval of our terms of reference every 2 years, which is why I've put the Living Life to the Full one in there. That again, there are no amendments to it, but I thought it was just part of the formal process. Am I correct on that, Julie, or if there's no changes, does it not need to do that?
That we ask the groups to review them every 2 years. If there's no changes, you don't need to get the council approval, just as long as you've gone through the process of reviewing them.
Oh, fine. Okay, so that's a misunderstanding on my part. That's why I got you to include them in these minutes. That's fine. Thank you.
Okay, so I suggest the next, I don't know who it is, Tom or John, goes on about the next committee group.
Okay, I'll talk about Living Life to the Full briefly then, if that's okay. I managed to lock myself out of my own meeting, which was a bit embarrassing in October. So I had a MS Teams update, which sort of lost all my settings and things, and struggle as I may, I couldn't get back in, but never mind. Jenny kindly carried on and played a video about recovery in mind to the meeting. This was something that I was really quite interested in, because for a long time we've tried to get the lady that runs Recovery in Mind to come and talk to our group, but for one reason or another she's not been able to do that. And it's very interesting to see that we were speaking with Graham earlier on, that it started off as basically a lady setting up things on her own, and it's moved on now to incorporating funding from the local authority and BHFT staff actually taking part in running the recovery college. And what we were going to go on to do in the meeting, which, because I wasn't there, we didn't get the chance to, was just look at what's happening across other localities, because I'm very aware that in the WAM locality, the local authority withdrew the funding for the Opportunity Recovery College at the end of the last financial year. So since April, we haven't had a recovery college as such in the WAM locality. And the staff in CMHC that are doing that are sort of doing other things. But it was really an interesting sort of difference in views, really, between our commissioners about what sort of model they want to follow. I mean, we've had Recovery College for a long time in Reading, and I think Slough was the next one. We were talking earlier that Bracknell is getting to the stage where there's again a volunteer setting one up. So there's this sort of disagreement about what's the best model, and it was just an interesting topic for discussion to go through there, really. So that's where we were with that. We've got a couple of things lined up for next year. Actually, in the first meeting, which is either January or February, can't remember. Katie Humphreys, that's the carer, family, friends and carer strategy lead, is going to come and update the group, because we're keeping this primary interest on carers within our group, because David Buckle is a sort of core member of our group, and the quality assurance group sort of takes an overview of carers, and so we're trying to keep that link together. And then later in the year, in July, we've got Zena Pike from WAM CMHT, who used to run the Recovery College, and is now both a lived experience lead and I've forgotten the name of the other classic mental health measurements. Never mind, but she's that lead in the trust as well. So we're carrying on this emphasis on carers for next year, and I would encourage, as I think some of the other reports have, people, these are open to all governors. I think if people got the time, they'll find them interesting. So thanks, Naomi. Any questions?
Thank you, John. Questions for John?
Okay, thank you.
Thank you. Tom, over to you.
Thank you. Well, public membership and public engagement group. So membership is holding up, and I think we do get some recruits through some of the services and so on. That's very good. So there's very little to say. The things are in the basics in the report. Now we've been finding out something about how the trust engages with the public, and what we've learned is that there are certain public-facing services that do an awful lot, and it's very difficult for governors, and I should imagine for board members too, to get an impression of the whole public face of the trust. Now, Marcoms knows what's going on, but it is very diverse. So, for example, there are the three websites: the main website, the Children and Young People, and the Talking Therapies have their own website. So there's three main websites to start with. And then we've got all sorts of other channels, Twitter and well, all those other things that young people use and so on. There's the YouTube channel. I've put some things here just for governors to have a try, have a look at it if they haven't looked at them. So there's the YouTube channel in which we've got board meetings and our own meetings. Some of these are available, by the way, by clicking on the icons at the top of the homepage. Anyway, you might want to have a look at this, and by looking at the video recordings of our meetings, you can count the number of times you scratch your nose during an hour or something like that. Okay, anyway, so it's very diverse, and the services in a way lead, the particular services lead in this sort of engagement. So that's been useful. And I think to understand that, we've started reviewing it, and if anybody would like to sort of become a semi-regular reviewer of any of these channels, they'd be very welcome, and it'd be good to have them. Do get in touch. Thanks very much. Now, we have discussed our terms of reference actually at a previous meeting, but I forgot to bring them to the council, so I've brought them to council now, and Jenny and Julie have kindly published them, and there's very little change. We've amalgamated two clauses because they were very similar, and put them into two of those responsibilities, and put them into one with a little tweaking. So that's the only change. I hope council will feel able to approve them. Thank you.
Thank you for that, Tom. Any questions for Tom? No, good. And Julie, could we just formally, unless there are any objections, could we formally apply ratification to the two TORs?
Yes, that's fine. Thank you.
Thank you. Thank you. Moving on, the governor's feedback session. So this is an opportunity for, I think, general commentary and feedback on the trust. If there are any burning questions or other topics that people would like to raise, now's the time. Thank you, team. Any other business?
Time for lunch, I think.
Time for lunch. The date of our next meetings, you'll have seen that on the agenda, which is great. 2nd of February for the next joint Council of Governors meeting with the NEDs, and the 9th of March for the formal Council of Governor meeting. Julie, I'm assuming that is in the diary, and everybody's kind of sound with that.
Yep.
Okay, good. I'm now going to ask. Oh, sorry, beg your pardon. Tom, go ahead.
Just to say, should we sort of plan ahead and decide when would be a good time to have a presentation on the new patient experience side? I mean, we want to let it bed in, and we want to be able to draw some conclusions. So 6 or 9 months sounds like a right time to schedule it, sort of, and put it down for a good presentation.
Thank you, Tom. I think that's a very good suggestion. As you would expect, Tom, this will come to the board. Sorry, apologies, my system's trying to do an update. For sure, the board is going to want to see results of it when the team is ready to provide those. But I really like the idea of giving the Council of Governors a presentation as well. So let's take that as an action, Julie. Thank you. With that, I'm going to ask members of the public and the press to leave us if there are any. I'm not sure there are any, are there, Julie?